PPE materials that we need to cater for the patients. Then it's strengthening the follow-up and provision of psychosocial support for those who have recovered. You have a number of those who have recovered, because the stigma also as a challenge in the community. So follow-up being really addressed to see that they get support and can come back to their normal lives in the community. Provision of PPEs, as mentioned, is one of the key areas that's being given priorities, especially with the response teams and the service providers, and the government is prioritizing this as a key area for solutions on the pandemic spread. Next slide. Yeah, lessons we have learned, one of the biggest lessons we have learned is the strong leadership, both political and the technical. We have had a multi-pronged approach. Everybody has been active and we've been really getting a very good guidance from the President of the Republic of Uganda and the ministers and the other technical people who are involved. There's a task force which has been in place and has been very, very useful to guide the control of the pandemic. So lockdown, the testing, quarantine, contact tracing, mobilizing resources, etc. They all need a lot of teamwork and the good guidance from the leadership, which has been a good lesson for so far. And of course, then the IPC, Security Prevention and Control measures being followed strictly. The program has been stepped up. We have the personnel facilitated to be able to execute the different activities in this line, and also making sure that the guidelines are there. We have the guidelines for the different, especially for this current pandemic, to guide the interventions across the country. So the teams have been working hard to see that this is also properly taking place as expected. Then identification of cases, especially triaging and screening in many places of entry points in facilities, quarantine centers, has been also a great experience and has helped us to identify those who need to get attention and be taken care of and get the services they deserve, they should get. And next, please, next. And the ongoing gaps, we still need the supply for protective gears, especially the masks. We are, as a country, we are agreed that all people in public places must wear masks. And this should be why we wish, and I think we are going to work around this to see that they are available and put to use, especially those who are in the public places. Then the clinical characteristics is also, which is not very, it is varying. I not say not clear, but it keeps varying from maybe one country to another. There's also a gap we have. We are moving up with most of the cases in Uganda we have had have not been typical COVID cases that we have seen in other countries with the difficulty in breathing and so on and so forth. But so that one is also, it can be an advantage on our side because we don't have very serious cases to manage, but it also can be a challenge in the times of preparedness, knowing what you need to have in place and what kind of cases you expect in the course of time. Then compliances, I've already talked about this in the prevention and control. And
especially, Doctor, you have to finish up now. We're running out of time.
I'm almost done. And the last two points we have about, again, they are related to some of the points I've read before, with the concern of the highly infectious virus that requires stringent IPC measures and therefore preparedness in that line. Sometimes we need to mobilize the resources and we have to look for the resources in that way. And of course, the waste management is still one of the issues we are also grappling with. Lastly, and last slide, I think. Next slide. Yes, yeah, appreciating all those who are working with us, the partners, and of course all the other stakeholders in different capacities who are supporting this effort to control the COVID-19 pandemic in Uganda. Thank you very much for the opportunity and listening.
Thank you very much, Dr. Martin. We just want to thank you all for your presentation. I'm just going to hand over to Africa CDC that will handle the questions and answers. Thank you.
Thank you very much, Anna, and thank you to all our presenters today. On the line today, on our panel session, as you've heard, we have Professor Shine from ICANN, we have Professor Shade and Anna, and Lizzie from ICANN. From Africa CDC, we also have myself and Mohamed, and we have from US CDC, Elizabeth, and Alice from WHO, and we will be the panelists for today's Q&A. So very quickly, I will just move to some of the questions that our colleagues have started to put online. So I think I'll start to take some of the questions. I think some of them are already being addressed by our panelists. I think we will start with ICANN. Okay, no, I think I should start with Dr. Martin. That was quite an impressive presentation, and there are so many questions here directed at you, but one of them that stands out is, what is the treatment employed for COVID-19 cases in Uganda, saying as Uganda has not reported any deaths so far? So over to you, Dr. Martin, to answer that question.
Thank you very much for the question. And the treatment basically has been supportive for the patients we have. Many of them have been asymptomatic and they have been quarantined for observation to see the progress of their condition up to 14 days. Those who have symptoms of headache and maybe flu, or cough, they have been given the painkillers, paracetamol, and the vitamins have also been provided for the patients with those mild respiratory symptoms. But generally, many of them have had no symptoms, although they are positive. And then they have been kept under quarantine and observed for the time until they improve, until until discharge time. Otherwise, so that has been the best, the general management. There's a lot of preparations for the difficult situations. They especially had regional hospitals and national hospitals prepared in the sense of those who may need assisted ventilation and other supportive care for the difficult cases. But I think so far, we thank God, you have not had those difficult cases.
Thank you very much, Prof. Shine. This is for you. So I have two questions that I think they're sort of related. So we have a colleague from Cameroon who is wondering how long the dead body can be kept before burial. The current policy in Cameroon allows only 48 hours. And the next question would be that how long can the virus survive outside of the host? Thank you, and over to you.
Thank you very much. So as far as keeping the body is concerned, it depends upon your usual practice. Like I said, there's no need to hurry, there's no need to rush. If your practice is like Muslims, that you have to bury before the sun goes down, then you will do so. If you are burying after being left in the mortuary for a week, that's fine too. So there isn't any reason to rapidly bury a body because it's not Ebola. Okay, so I think that is probably quite clear. The second question was about the survival of the virus outside the body. There are several papers published now, but the one that comes to mind off the top of my head is a Camp's paper from 2020, where he looked at many different surfaces, and some surfaces which would allow the identification of being able to find the virus after 7 days on certain surfaces. That was in laboratory conditions, in the absence of any cleaning or disinfection. But I want to just remind you that these studies show the presence of the virus, which is the RNA detection using PCR. It's not the viability of the virus. Only 2 studies have shown viability of virus, and those are usually within 72 hours. They can show no viability of the coronavirus, SARS-CoV-2. Those are the only two papers that come to mind, sort of like immediately. But I'm sure there are more publications around.
Okay, thank you very much for that. So, Prof. Shade, if you'd like to take the next question. It says some viral footages of health personnel dragging or forcefully taking patients suspected of SARS-CoV to isolation centers in some countries have been on the internet for a while. So what do we say about this non-ethical behavior of our colleagues? Shouldn't they be isolated along with the patient? So this is quite an interesting one. So Prof. Shade, if you'd like to take a go at it.
Thank you very much. I don't know how I'm going to take a go. Unfortunately, I have not seen the videos. I have heard of them. Technically, nobody should be dragging people into vehicles to take to isolation centers. However, the next question was if they need to be isolated themselves. I think that depends on how they're dressed. They would go to self-isolation if these people are infectious and they're in close proximity and they're having that much engagement. They should go on self-isolation themselves. If they're fully clothed with masks and everything, then they probably will not, because then there wouldn't have been an exposure. So, but it is not ethical. Thank you.
Okay, thank you for that. Again, re-emphasizing that it is unethical to practice that, and we don't support that as all of the various organizations which we represent. So Elizabeth, I think this question I will throw at you again for us to learn from the United States experience and the US CDC's experience. The question is, if face masks are worn, should there still be social distancing? So if you'd like to take a go at that question, Elizabeth.
Wande, I'm so sorry. I just dropped off and jumped back on again. So all I heard was, would you like to take that question, Elizabeth? Would you mind repeating it for me?
Sure. So the question is, if face masks are worn, should there still be social distancing? So I think it would be good for us just to unpack it a bit, looking at what kind of face masks the participant is referring to, and we can just look around that. So if you would like to just take a go at the question from your own experience, over to you.
And you're talking about people who are participants at a funeral, yes?
I believe that would be the context of this conversation.
Yeah. So sure. So WHO, as you know, is coming out, and CDC is coming out with recommendations of just face masks or what they often call face coverings to differentiate them from the face masks that are truly used in healthcare settings. So cloth face coverings to be used really anytime that you're in public, where there's the possibility that you might transmit or that you might receive the virus. I think to be on the safe side is to use if you're going to a funeral, is to use a cloth face mask to as much as possible, because we know the cloth face masks are not 100%, not going to protect you 100%. Is as much as possible to use social distancing. I do recognize it can be tough in a funeral where you want to have that closeness.
I think we lost Elizabeth there for a minute. So Prof. Shaheen, I see very interesting. Elizabeth, we lost you there for a minute.
Yes, you did. I'm sorry, I'm in a place where my internet is not very good. But anyway, I would suggest wearing cloth face masks I would suggest as much as possible, social distancing, good hand hygiene. And as Prof. Shaheen said, people who are at high risk for acquiring the virus, people 60 and above, people with diabetes or other serious comorbidities, should consider, if at all possible, not to attend the funeral or really not to attend any social gathering where there may be people who are transmitting the bug to them, unknown to them. Over.
Okay, thank you so much for that. Prof. Shaheen, I think this is directed to you. It says that there's been reported confirmed cases in morticians and training states. This is one of our epidemiologist volunteers in Nigeria. What is your take on the risk of morticians in the face of this pandemic? So over to you, Prof.
No, thank you. No, I thought I covered it, but let me just reiterate. If the body is closed and nobody's fiddling with the body and you look after it with the respect it deserves and you bury it, it's fine. If you're going to start opening up the chest, or if you're going to start doing a post-mortem, or as the Americans call it, an autopsy, then the chances are that if there is virus there, then it is possible for that to be aerosolized because you're pushing down on the chest. When you're drilling open, for those of you that have ever done a post-mortem, you know, you have to actually press onto the chest because you've got to cut the sternum open and then break the clavicles off in the side so that you can actually open the chest. And then you have to cut underneath the rib cage. So all that activity allows for movement of the chest. If you haven't understood what's going on, and if your ventilation is poor, and you haven't got proper PPE, that is where it all started from. Oren presented a very nice paper not so long ago saying that the morticians didn't recognize the movement of the virus and therefore were undergarbed and were underventilated for the environmental ventilation. So since that has been dealt with, those chaps that got infected were unfortunate, I think. And since then, I think we haven't touched wood. I don't have any reports from anywhere saying that people handling bodies have been infected. In fact, there's nobody who's actually reported direct infections from handling a body. It's only if they've been fiddling with the body or cutting the body.
And this is Elizabeth, if I may, to back up Prof. Shaheen, which is we don't see a disproportionate level of infection in funeral directors or people who handle these bodies. It's not like in Ebola where you really see a disproportionate number of people who are in charge of bodies getting ill with the disease. You may see some morticians, some funeral directors, some people handling the body, but it's at probably the same level as what might be in a community transmission situation, except of course for those who were directly doing an autopsy, a post-mortem examination, and really getting into the lungs. But otherwise, you don't see disproportionately people handling bodies being infected, as long as they're doing it properly, as Prof has outlined.
Okay, thank you very much. We'll come back to Dr. Martin, but before I go on, we are live streaming on Facebook and we have quite a number of participants on there. So please feel free to drop your questions. We will be able to take some questions from Facebook. Please put your questions on the chat function on Facebook and we will be able to take those questions. So very quickly, Dr. Martin, this comes back to you. There are quite a number of questions for you. It says, what is mandatory testing and how have you been able to deal with the accumulation of waste at the various isolation centers or treatment centers? So it's a sort of two-in-one question for you. Dr. Martin, over to you.
Yeah, thank you very much. Mandatory testing is what we was instituted to minimize entry of suspected cases into the country with the coronavirus infection. So at the border sites, especially, all the truck drivers and the other maybe who are authorized to cross the border have to undergo a mandatory test for COVID. And we thought it was a very important intervention to ensure that people entering the country don't come with an infection. And it has been very useful in identifying and getting to the suspected cases so that they can be guided on the next steps so that the disease does not continue to spread into the country. And so that was basically at the border points. And at the time we had, when the airport was still functional, they also had mandatory testing going on. The accumulation of the medical wastes at the testing sites and also the places where we are seeing patients, and maybe we are getting these wastes accumulating. The workers have been sensitized, first of all, to handle them the way they handle the healthcare wastes in the normal way. That is being careful in disposing them off, disaggregating the wastes, and also having them properly packaged. And for places, service delivery points, like in which are not the usual places we use for seeing patients, then these are collected and transported safely to the nearest points where they can be disposed of finally. And you have the regional fire hospitals where we have incinerators instituted. And also some of the rural facilities, they have also places for managing the healthcare wastes. So that's our work we have been doing for now. And we hope and are planning to see that we improve, because the challenge keeps growing with the number of cases increasing. Thank you very much.
Thank you very much, Dr. Martin. This question says, I think the question really is directed at Africa CDC based on the epidemiological data about the report shows that Eastern Africa is the highest. Just to correct that, it's Southern Africa who is reporting the highest number of cases. So the question goes on to say, what kind of involvement, support, concerned with African CDC to show us? I think the person just wants to know what Africa CDC is doing overall in terms of supporting countries, in terms of handling and helping and various investments. So I think I will take a go at that. So for us as Africa CDC, in February, we launched the Continental Joint Plan with the Ministers of Health from the 55 member states. And we have various technical working groups working on so many parts of, in terms of the response, looking at surveillance, infection prevention and control, case management, supply chain, science, to touch on a few. So, and laboratory. So one of the things that I would just highlight, which we have tried to do in all of our previous sessions, was just to show an highlight of what we are doing, just like this, as part of our infection prevention and control activities. Prior to the lockdown, we had we had trained over 40 countries, trained the IPC focal persons and the point of entry healthcare workers. We have also led distribution of PPE to ensure that all of the 55 countries are able to access adequate supplies of PPE. We have also worked with private, public, philanthropic agents such as the JACMA Foundation, the MasterCard Foundation in distributing adequate PPE. We recently launched a pact initiative to improve contact tracing, and we are looking on to deploying over 1 million community workers to support contact tracing across various countries. You may also be aware that right now we have been able to deploy using our special AU air corridor system. We have been able to deploy over 150 epidemiologists and various other experts to about 14 countries across the continent to support with this response. So that's just a few of the things that we are doing. If you go on our website, we're putting that on there, and hopefully next week we will be able to give an overview just to our new participants what we have been doing to support our member countries. I hope that was very helpful. So very quickly, I think we still have some other questions again for Prof. Shine, looking around handling of dead bodies. This question is for social gatherings like weddings, funerals, churches, mosques. Is cloth masks and social distancing enough to prevent infections? So Prof, if you want to take a go at that.
It's a really good question, that actually. If the 50 people there are all wearing cloth masks, then I protect you and you protect me. So the transmission in the air around you is much less. If we then supplement that with the social distancing of 2 meters or 1.5 meters or whatever we want to do, it reduces it even further. So the load in the air around, the closer you are, the more droplets you're going to be in contact with, right? We know that. So if the further away you are, the fewer droplets, but maybe there's some aerosols. However, if you wear face covers, those aerosols are reduced as well as the droplets reduced. They're not stopped. They're not completely closed off like N95, like the respirators are, but they are definitely reduced. So if I'm wearing one and you're wearing one, it's protective. So it's very, very effective. And I think if you, the last pictures we saw of funerals where they had chairs placed quite far outside in the garden and everybody was sitting there and paid their respects from where they were. Even when they walked around the coffin, they spent, they did that 1.5 to 2 meter thing. That's fine, absolutely fine. I think the point that we mustn't forget is if somebody has died during this period, to be honest, you will not see them again. And it is very important from every point of view, particularly in Africa, and my African colleagues tell me this over and over again, to do that ritual in a way that everybody remembers that person. Okay. So you can still do it. And this is why it's quite interesting to see people doing live streaming on videos and things to make sure that people are still part of the whole action. So yes, so for me, hand hygiene, face mask, cloth masks, and social distancing at a funeral of a few people, preferably outside, not inside the house, is good. It's fine. Over.
Okay, great. Thank you so much for that.
But I have a question for Dr. Martin, if I may. Am I allowed to
Yes,
ask?
please.
Dr. Martin, an excellent presentation. Thank you so much. I just wanted to know what you're testing for COVID-19. What was your, you might have said it and I missed it, but what was your testing policy for COVID-19?
Testing policy.
Yeah, thank you very much. And the testing policy we had was mostly for the suspected cases
High risk groups.
from the high risk groups. In the first place, we had those who are traveling from countries who had many instances of the COVID pandemic. Then eventually we extended this to people who are coming to the country, especially travelers coming to the country from the border points. So all those ones are subjected to testing for COVID. And then we carried out to the other area we went into is for the community survey, where it was random sampling among the communities that we see, we get a broader picture of the situation on the ground within the community, especially then.
And also with the case definition.
So, and of course, we had to follow the case definition or to see those who are suspected to be having
For example, you're not doing routine testing of healthcare workers, for example.
No, we do not. We have not been doing that, and there are some cases when it would be compelled to do mass testing for in some institutions, where we get sporadic cases arising. Then we can subject the individuals in that community, in that institution, to undergo a testing to identify, but not mandatory, definitely, but people will be obliged to test, and so that if there's anyone who is affected, this person can get the service and is assisted to prevent the disease from spreading further. So that has
You wouldn't be picking up asymptomatics, for example.
Sorry?
You will not be picking up asymptomatics because you're not
necessarily.
Well,
unless, as I've mentioned before, people are coming to the country, you don't want to have to test them. And,
thank you very much. Thank you.
Thank you.
Okay, thank you very much. I see another question for Africa CDC. It says that most tertiary hospitals, especially had to wind down some of their services to handle COVID-19 emergencies as treatment centers. As Africa CDC develop any protocol to be used to return hospitals to the new normal? We recently published a document about maintaining essential services, health services. That is on our website. Please have a look at it, and feel free to reach out to the Africa CDC email should you have further questions about a protocol that you might need in your country. So I think this question is quite interesting, and I think we can be, our panelists might be able to chip in individually on this. So this is from one of our volunteers on the field in Zambia, saying that I'm concerned with the increasing complacency of the public in Africa. Like Uganda, we are also seeing some complacency in Zambia, and similarly we saw something on BBC in Nigeria. How can we start to design risk communication messages to address this? So I think, again, going around the fact that everyone is getting very COVID out or is a burnout from COVID. So our panelists, if you have any from your various experiences across South Africa, Nigeria, Uganda, please, and the US, please, if you would like to chip in on how healthcare workers and frontline workers can improve the risk-com messages to address this. So Anna, if you're on the call, if you would like to take a go at that.
Sorry, Wanda, I was just busy with the questions. I didn't listen properly. Can you just repeat that for me?
So it's just, how do we improve our risk-com messaging? Because people are seemingly getting tired of us telling them wash their hands, use face masks. So any ideas on the things that we have been saying since February, if we can improve this, at least for the community, so that we can keep people practicing this?
I think personally myself, we feel that, we need to be an example. So it should be a way of life, and we should do it in a way to not be threatening to people, but rather help them and assist them in a nicer way, the way that we address them. And also we need to make sure that we talk to the traditional healers and the traditional leaders in the communities, because that's also help if they understand what it's all about. And Professor Meta will agree with that. We've been saying that all over. They should realize it's not just about COVID, but it's about IPC as part of our, always in our community and in our facilities, that we should address it as always. And it's just a good way of preventing yourself from getting any disease, not just about COVID. So I think the way that we are talking to people, the examples that we are following them, making sure that they understand how we treat them with dignity and with respect, and not just giving them a stigma because of the way that we are handling them as well, will make a difference. Prof. Meta, I don't know if you and Sade want to say something else.
Thank you. I totally agree with you. I mean, I think because the people that are delivering care are just as scared as the people that are receiving care, we have a tendency of making an us and them situation. And the messaging, something like this, has got to be very gentle, very delicate, particularly in the environment where people are either elderly or they've got more than one comorbidity. Certainly in South Africa, we've got people who've certainly got more than one comorbidity with diabetes, hypertension, but they've also got tuberculosis and HIV. So the idea, there is stigma. I mean, we have the most cases in Africa. I mean, we have this experience of dealing with stigma all the time, and including community health workers not wanting to screen people, things like that. There's some quite awful things happening out there. And the question is, how do you message something like this? Because on one hand, we're telling them to be afraid of transmission. And on the other hand, we're saying to them, well, actually, you should be afraid and safe against transmission. So the two questions, or the two responses, are almost contradictory, in some ways. So the Ministry Advisory Committee has now got a social behavior group working on this. and very much learning lessons from the HIV epidemic and the TB epidemic to see how we can put the statements and questions out there. And it seems to be that posters where people can read for themselves gives a very good indication of what's going on. The second thing that gives a very good support program are people talking to other people in a sympathetic way, not in the dragging into the that we just heard about people being violent. And I mean, this happened with the police, as you remember, in South Africa earlier. The police are violating people. In fact, a couple of guys got killed in the process because nobody knew how to deal with this. They were just looking at this really heavy-handed way of behaving. And I think all that has got to be put in the perspective of how we talk to people with respect, as Anna said, you know. We could be at the receiving end of this any day of the week, to be honest. And so it has to be very respectful, and the message has to be culturally sensitive. The language should be culturally sensitive. So it's no point in giving them long statements in English when actually they speak Xhosa or Zulu or something else. You know? So I think we have to get our head around that as well and do it properly. Again, coming back to it, that if we had the leaders, the traditional heads on our side, the messaging would be far, far better within the psychology of that community than if people came like myself, speaking in English and not really quite understanding what's going on. I would strongly recommend that there would be different ways of messaging in different parts of the world. And like in Europe, the messaging is very different because they have a homogenous population. In South Africa, we don't even have a homogenous population. We've got 11 language groups, you know. So how are you going to get that message across? And how well can you get it across? I see Sade's come online, so she might want to say something.
Thank you very much. I actually agree with everything you've said about the cultural context. I think there are also a number of things that are mitigating. I'm looking at Nigeria. We're almost like the United States. Different governments, the governors of states, at different levels of belief, denial of activity, so that there's a lot of confusion to being shared amongst the people. But one of the things we can add on a positive sense is we might have to engage groups. For example, the market women groups, they have a lot of influence beyond the marketplace because these are strong women in the community and they really do have a voice. Groups of, because a lot of people, as you said, the complacency, and I think a lot of that comes from the fact that we were expecting to see Europe in Africa. We're expecting the high death rates. We're expecting to see people dying on the streets. And it's almost like a non-event. So there are many people feeling that maybe this is a hoax. I still hear that they feel it's a hoax. It's big. We're beginning to see more deaths, and I think we were going to see more cases. But if we're going to talk to people, as you said, we have so many languages, we have different levels of understanding of English. We need to talk to the opinion leaders in the community and engage them so that they actually do the messaging. I'm not sure in many places, a lot of the people on the ground believe their government per se. So we might need to deal with the people they believe. So as Shaheen said, we've got to get the traditional leaders with us. We've got to get the community groups and leaders, the youth leaders, the market women, you know, the artisan groups. We have the truck drivers. Almost like we did, in fact, not almost, like we did with HIV, we had to approach all these groups because they're constituencies and they know how to speak their own language. So we've got to get them on our side. And I think that's the only way to go, because COVID is here for a long time. And people are just tired, you know, they're just tired. You know, their businesses being shut down and so on. So that's what I'd like to add on to everything that's been said, which I agree with. Thank you.
Okay, thank you very much. Thank you very much to the panelists. It's been a very engaging discussion. Thank you to our participants for very insightful questions from various parts of the continent. We're looking forward to doing this again. And I think I can hand over to you to wrap up the session. Thank you.
Thank you very much, Wanda. And I want to thank everybody for their time they spend to come on to the webinar. I want to thank all our speakers, Professor Mehta, Dr. Martin, all the panelists, and everybody that posted some questions. If you do have some more, you can always reach us at Africa CDC or ICANN, and we can try and see if we can address this. And then please just also join us next week, Wednesday at the same time, for our last in this series. And then on Friday, we will have a French session, the same one as now. And then after that, we will also let you know when we start with the next series of presentations that we're going to keep on running over a period of time. Thank you, everybody, and thank you for your time. And have a good day.
That the QR code is on the screen, and please answer the quick poll questions to help us improve your understanding of the topics. Thank you.
QR codes is also in the Telegram. If you all on the Telegram, just look, they will be available until about after 2, but after that it won't work. So just remember to scan the codes, the start and then the end code as well. Thank you. Thank you, everybody, for your time. And we will still be available on the Telegram as well, so you can also post your questions on there, and we will see how far we can address them. Thank you. Goodbye.